all of you know skin layers. We have mainly 4 layers in our skin. First layer is epidermis, dermis, subcutaneous, and muscle layer. All of you know, no?
Please respond. You can respond in chat box also.
Yes, ma'am. Okay. Okay. So, this is a infusion. All of you know that the hypodermoclysis or subcutaneous infusion is an infusion or giving to the particular layer. So, we can move on the exact topic. So, subcutaneous infusion, otherwise known as hypodermoclysis. Hypodermoclysis, which can also be called interstitial infusion or subcutaneous infusion of isotonic fluid into the subcutaneous space for rehydration or for the prevention of dehydration. That is for the prevention of dehydration or to rehydrate the patient, we are given some isotonic solution to the subcutaneous layer. Actually, commonly we are infusing the fluid to the which route? In which route we are giving infusions or fluids for a patient? In common setting?
Intravenous.
Yes, IV. In most common is IV fluids. In our setting, in some sort of injection also giving through the subcutaneously like insulin and all. But this large quantity of fluid is given to the subcutaneous in our setting. This is called a subcutaneous infusion. Okay, clear? Any doubt regarding this? Okay, clear. What are the indications for the subcutaneous infusion? We actually covered that in definition. We are giving subcutaneous infusion for prevention of dehydration or the rehydrating the patient. So ideal for preventing dehydration, mildly to moderately dehydrated. Next one is we are giving the patient with severe dysphagia. What is dysphagia?
Difficulty in swallowing.
Okay, difficulty in swallowing. Otherwise, very painful swallowing is also called as dysphagia. Swallowing difficulties or confused. Sometimes some patients they are in disorientation, some confused state. Maybe because of disease condition or any diminished values of some sodium and all, there is a confused state will be there. So that time the patient is not able to swallow or not able to take anything orally. That condition also we given subcu fluids. The fluid needs less than 3 liters per day. Some patients may need 3 liters of fluid per day. Where there is a very difficulty to put the IV line. That patient also be gone through the subcutaneous infusion. That are the main indications for the subcutaneous infusion. Prevention of dehydration for giving rehydrate the patient or patient with the dysphagia or swallowing difficulties and patient who needs fluid less than 3 liters per day. In common indications in palliative care is the patient who has nausea and vomiting. The patient may be manifested by nausea and vomiting, continuous nausea and vomiting. There is very difficulty to put IV line. The oral medicines are not tolerating means we have to give a subcutaneous infusions or subcutaneous fluids or subcutaneous injections. Mouth, throat and esophageal lesions. The patient may have any lesions in mouth, throat, or esophagus, there is a chance of getting swallowing difficulty, or otherwise there is the nose pincher control. So there is also we given subcutaneous infusions. Then interstitial obstruction. All of you know that interstitial obstruction means nothing but there is obstructing the intestine with any mass or any fecal matter sometimes. Unconscious patient. The patient with diminished conscious level and intractable symptoms that are not well controlled by oral methods. We tried oral medicine for vomiting, nausea, or other pain also there. So there is not at all controlling with oral medicine. We manage him with the sub-Q or IV. On rectal route is inappropriate. All of you know that in morphine and all we given rectally also sometimes because of oral cancer is there, patient is having more pain means we tried with the rectal route. Sometimes it is also very difficulty due to any lesions in the rectal cavity, maybe because of patient is having loose stool. That time we can't given any medicine through rectally also. That time also we go to the subcutaneous infusion. Is it clear? Any doubt means you can ask through the chat. Okay. And some site are there. Commonly in what are the site of subcutaneous infusion? Anybody? All of you in our setting, all of you know subcutaneous injections like insulin and all daily living. We are given to some patients. So what are the sites of subcutaneous injection or infusion? Anybody?
Upper arm, leg, abdominal.
Abdominal.
Thighs, thighs, abdomen, forearms.
Yeah. So some site are there. Upper chest, upper arm, abdomen, outer thigh, upper back, scapular area. Most commonly in our setting we are using upper arm, upper chest is there, abdomen, outer thigh, sometimes scapular and upper back. So in in right side of the screen there is a into mark is there that the not we are not giving these sites also lymphodematous areas because we are put any sub-Q line or IV line to the lymphodematous areas. It will cause the breaking of skin and it will causing oozing of fluid from that area, so it tends to getting a more infection to that area. So we have to avoid lymphodematous areas to put the injection. Then skin site that have recently irradiated. So any skin changes are there, we have not given to that area. Okay. Next one is bony prominence. If we put a IVs or subcutaneous line in bony prominence, what happens?
They don't know.
Injury to the bone, ma'am.
Okay, injury to the bone or surrounding tissue may happen due to we place a needle to that bony prominence. Sometimes the movement will occur. That time it will injure to the surrounding skin or bone. In close proximity to a joint, same as that also, skin folds. It will causing some edema, more edema in that area. It will causing the medication will accumulated to that area. So skin folds also we not chosen. Inflammation and infection sites, ascites or pitting edema sites, and tumor or scarring. These sites have to be avoided to the subcutaneous infusion as well as the IV. this is the most common sites. We already discussed the upper chest, outer arm, in the abdominal area, scapular area, and thigh region. So which are the medications we have given through the subcutaneous line? Most commonly, which medicine is given through subcutaneously?
2% Zailocaine, sometimes heparin, Heplac solutions also, ma'am.
Most commonly in our setting and home care as
The
well as I think
tuberculosis,
insulin. And most low molecular weight heparin we given through the subcutaneous line. Some vaccines also given through the subcutaneous line. And in our setting, most common medications are injection morphine sulfate, injection haloperidol, injection midazolam, injection metoclopramide, injection hyoscine butyl bromide, and injection fentanyl. These are the most common medicines used in the palliative care setting. These medicines we can give through the subcutaneous line. And Stemetil, Dicima, and other category of Stemetil is chlorpromazine that we can't give into the subcutaneous line because it's a oily preparation. So oily preparation and all we very difficulty to absorb through the subcutaneous line. So that's why we can't give these through the subcutaneous as a subcutaneous infusion or subcutaneous injection. So is it clear? Yeah, Clexane. Clexane also a low molecular weight heparin like preparation, no? Next, go on through the procedure. First, same like other procedures and there is some common step will be there. Explain the procedure to the patient. We have to maintain the privacy, gathering the all equipments in bedside, and hand washing to be performed. These are the main basic procedure steps are there, including that these also there. Explain the procedure to the patient, wash hands, assemble the fluid and tubing to the bedside, and prime line with selected fluid. For what purpose we have to prime the line with selected fluid? Actually, the subcutaneous infusion will given through the scalp vein set, no? We have to put a scalp vein set to the subcutaneous site instead of IV cannula. Okay. So the subcutaneous line means the scalp vein set has a long tubing, no? So we have to put the subcutaneous line directly to the subcutaneous tissue. There is a air embolism may happen because the line will be full of air is there. We have not primed the line means first we have to give injection means the air will be going out to the subcutaneous site. So once we prime the line means we put an injection that fluid will go to the skin layer. So we have to prime the line to avoiding air entry. The air entry is very painful in subcutaneous site. So before you are going to start the subcutaneous injection, subcutaneous line insertion, prime the line with a selected fluid. Next is swab the site with the antiseptic solution using a circular motion from center to outward and leave to dry. Then do not touch the prepared site again with fingers to avoiding infection. Insert the needle bevel up into the subcutaneous tissue at 30 to 45 degree angle. You already we explained the skin layers. The needle has very low length is there. So we have to put a 30 to 45 degree angle. We have to give a for 30 to 45 angle needle insertion will be given. Next is secure the needle and tubing with the occlusive dressing to avoiding the misplacement and adjust the fluid drip rate as prescribed. That is the main procedure steps for subcutaneous infusion. First of all, we explain the procedure, wash hand and gathering the instruments to the bedside and the prime line with the selected fluid. After cleaning and keep the leave it to dry and take the needle and bevel up and insert needle into the subcutaneous layer in a 30 to 45 degree angle and secure the line with the occlusive dressing. And adjust the fluid drip rate as prescribed. We can go through video after some time. Regarding the oleum, how much we can given through the subcutaneous line at a time or per day. All of you know the 1 ml is equal to 20 drops. It's a standard calculation. We can give 20 drops per minute accordingly. In one side, at a time, we can infuse the fluid like 1.5 liter per over 24 hours. That's a maximum. Okay. For at a time, we can put 2 lines in our body. So per day, we can give 3 liters in a over 24 hours for 2 sides. So one side is 1.5 liter. For each side, we can give 1.5 liters over 24 hours in 3 liters per day. After the procedure, do not set drip rate to deliver more than 1 liter in 2 hours. Sometimes we put the drip rate in very fastly. It will cause finishing the fluid within 2 hours. It will cause the very edematous to the particular site. So to avoiding this edema, so we have to adjust the rate accordingly. Document infusion fluid on medication chart. Check the patient and infusion after 1 hour to ensure that the infusion site is correct, that there is no signs of edema or leakage. Anyway, we check the infusion site, no? Because any redness is there, any edema is there, any irritation is there, we have to check like these symptoms. If any necessary means, we have to change the site. Otherwise, we can try it out. If we notice that there is more edema means, we have to stop the infusion at that point or reduce the drip rate and wait for some time. If the edema is relieving, we can start over. And also sometimes we have to give a simple massage to the edematous side. It will absorb the extra fluid from that side. What are the advantages of the subcutaneous line? It is a low cost. All of you know that the IV cannula is very costly. Instead of giving infusion through IV line and so we can give the subcutaneous infusions through the subcu line or to the subcutaneous tissue. More comfortable than IV administration. What are the things we have to face while doing IV cannulation? Can we get easily an IV? No, because in palliative care patients may get very difficulty to put an IV because of after chemo or radiation they came to our setting for the management. That is very difficulty to put the IV line. Many times we face that situation. That time subcutaneous line is very easy and very comfortable for patient as well as caregivers and staff also. So very more comfortable than IV administration, less likely than IV administration to cause pulmonary edema or fluid overload. In IV line angle directly it will circulate to the lungs and heart. It will cause the pulmonary edema and also have sometimes fluid overload will be there because the patient may have some any system failure is there means it will accumulated all over the system and it will causing the pulmonary edema and fluid overload. Simple insertion less than distressing than IV, easier reinsertion at new site. That is the very main thing. Simple insertion. If we take sometimes more than 30 minutes to find out an IV. In case of subcutaneous line, very easily we can put the subcutaneous. So it is very less distressing than IV. So more suitable for home care than IV line with less staff supervision. If we put an IV line, there is a chance of getting bleeding from the IV line. Sometimes it will get the IV line out. It will causing the edema to that area. Thrombophlebitis will happen. There is a direct supervision is needed sometimes in IV fluids. So in case of subcutaneous line, we can put the subcu line to that patient and educate the family members regarding how to put a subcu line to that patient again. And caregiver also comfortable to put the subcu line. In our setting and all, in our home care areas and all, the primary caregiver will do easily doing the subcutaneous line insertion. They will give IV subcu fluid through that particular line. So it is very comfortable. Does not cause thrombophlebitis. There is a chance of infection is very less than IV. Has not been shown to cause septicemia or systemic infection. Can be started and stopped at any time. No danger of clot formation. That are the main advantages. The advantages of subcutaneous line. Disadvantages is possible irritation is inflammation at infusion site. Sometimes some patient may get some skin irritation will be there and infusion site may inflame. This is the main disadvantages. Possible leakage of subcutaneous site. We can put the subcutaneous line on means we can stay back at for 3 to 5 days at same site. So sometimes for after 3 days, there is a chance of getting leakage from the site. So this is the possible disadvantages. Allergic reaction it is very rare. Sometimes it will cause allergic reaction to the skin. These are the some possible side effects and complications. First one is localized edema. Anyway, we given subcutaneous fluid means there is a small swelling is there. Sometimes it will more than small. It is localized edema is there. For that, we can give a simple massage to the localized edema. It will by absorb selfly. So, edema around the site of insertion of the subcutaneous infusion device usually resolves spontaneously or with massage. and inflammation or cellulitis. It is associated with poor insertion technique or management of insertion site. This is the inflammation in cellulitis. We already discussed that that is very rare. If it happens, means it may be because of insertion technique mishappening or management of poor management of insertion. This is the main reason for inflammation or cellulitis. Otherwise, it may not happen. Pain or discomfort at insertion site. It also very rare, but can be associated with fast infusion rate. We already says that we can infuse 20 drops per minute at a time for a patient. For 24 hours, we can give 1.5 liter at the site only. So sometimes we will given more than 20 drops. It will cause the pain. So we have to adjust the infusion rate. If the patient is saying that I have more pain after starting infusion, means first we have to reduce the infusion rate and check the site. It will sometimes it will happen. If the pain is more in that site, means we can change the site. Sometimes we can change the site also. Puncture of blood vessel during the insertion. It also very rare in subcutaneous tissue and all. We have to take we have to give a insulin. No, we have to take the skin with our 2 fingers and hold it out and take the needle and in 30 to 45-degree angle we have to put the needle to the skin. That time there is a very rare chance to get the puncture of blood vessels. If sometimes happens because of if the patient is bedridden, we put a subcutaneous line and left. That time there is some movements will be happen during the restlessness or otherwise positioning. That time there is a chance of getting puncture of blood vessels. So that if you notice any puncture site bleeding and all, remove at that time and put the new subcu line. And hematoma around insertion site. It also very rare, associated with low platelet and patient receiving anticoagulant therapy. That patient will get the hematoma. Infusion device occlusion. We know the subcutaneous infusion is we are given through the syringe drivers instead of giving syringe pumps. So any occlusion to that device, it will cause the irritation to the skin. These are the main side effects and complication of the subcutaneous infusion. And the main nurse's responsibilities are inspect the skin every 4 hourly. For what purpose now? We already discussed that you to identify the skin irritation like tenderness or hardness at the skin, presence of hematoma. Any hematoma is there means you have to remove the subcutaneous line and reinsert in another site. Leakage at the insertion site, local tissue irritation and redness, that is erythema, and presence of blood in the tubing, misplacement of the cannula. Cannula means nothing but cat pain set. So these are the main nurse's responsibility.
In your article ka mo,
I already said that syringe driver. No, anybody saw syringe driver? I think all of you know about syringe pump. Syringe driver, anybody?
yes ma'am, insulin.
Yes, ma'am, we have in our setting.
Did you have a syringe driver?
Yes, ma'am.
Okay. The syringe driver is a small portable battery driver infusion pump used to give medication intravenously or subcutaneously via syringe, usually over 24 hours. In our setting, there are two types of syringe drivers are available: on-hour syringe driver and 24-hour syringe driver. We usually practicing with on-hour syringe driver. We can set the medicine in hourly basis. For the continuous subcutaneous infusion as well as the IV infusions. This is the instrument called syringe driver. It is easily it is easily we can portable to the patient, so we can carry it to anywhere. Patient is very comfortable with the syringe driver. And next one is part of syringe driver. This is nothing but it has a syringe port area is there, and measurement is there, and adjusting device is there. So these are the main parts of the syringe driver: actuator, syringe plunger placement site, syringe finger grip, securing strap. It is used for secure the syringe to the syringe driver. Syringe barrel is there, syringe nozzle and extension set. The extension set is attached to the subcutaneous line or IV cannula to delivering the medicine. According to the measurement scale, we adjusting the dose and set the dose in the rate setting. We are giving in 24 hourly basis. Sometimes it will be in on hour. So indicator lamp is indicate the some flashlight is there. When the medicine occlusion is there or otherwise the medicine is finished means the light will off, and according some sound also coming, any occlusion or any disturbance in the medicine delivering is there means some sound will come. It will indicate the machine is not working. That time we have to go and check the syringe driver. Otherwise, every 4 hourly we have to check the syringe driver and as well as the site of subcutaneous line. So, any doubt?
Hello. Hello.
Okay, yes, you can speak. Any doubt means you can ask, no?
If you have any doubts, you can unmute yourself or you can put it in the chat box. Our facilitator Shiva ma'am has joined. Welcome ma'am to the session.
Thank you, Sangeet. Thank you, Sreedevi, for giving a lecture on subcutaneous infusion. Anybody have any doubts or any clarification needed? Please ask. So this is one of your new thing. I think we all know subcutaneous injection, but we don't know how to give. Most of us don't know how to give subcutaneous infusion. So in palliative care, this is one of the major part. We usually give subcutaneous infusion. So if you have any questions, please ask. Try to clarify your doubts now. Question to you, Sreedevi, how many days we can keep?
We can keep the site is up to 3 to 5 days. Sometimes it will. Some patients may keep for some 6 to 7 days. Also, some patients keep the site like same. We have to check every 4 hourly to the site. Any erythema is there, any skin irritation is there, so much edema is there. Means we have to, any leakage is there. Then we can remove the site. Otherwise, we can put like same as for 3 to 5 days.
Yeah, yes, as Sreedevi said, that is one of the important thing. As nurses, we should check the site every 4 hour, at least every 4 hourly. We have to check any signs of infection or leakage or anything. Otherwise, you can keep 3 to 5 days or in the same site. If you don't have any, if you don't that. No, if you don't see any that signs and symptoms like or any in the signs and symptoms of infection, you can continue the same site for infusion. Thank you. I think one more question.
Yeah, sometimes swelling or edema comes, can we continue the same set? We already discussed that some edema is there. We can stop the infusion for the while, because to adjust the rate. The infusion rate is more, means there is a chance of getting swelling or edema. After that, we have to wait for 15 to half an hour. If edema is there, we can give simple massage to that area. After that, we check the site. Still edema is remaining, means then only we can remove the site. Otherwise, we can continue with the same site.
So I can add one more point along with Sister Sreedevi's point. So this is one of the new method, as I mentioned earlier. When they come to you, they only know intravenous infusion. They knew that. And also the nurses will be saying to the caregivers, if there is any swelling, please report us. That is the message they used to hear from the nurses, because that is the intravenous infusion. This is subcutaneous infusion. The edema in and around the site is normal. That is the important message you have to convey to the patient and relatives before inserting a needle. Make them understand that there is an edema there that will be subside soon. It will not irritate. If there is a small pain will be there, but gradually the pain is also subside. You can give 1 ml per minute. That means 20 drops per minute we can give. But after that, after a few hours, the edema will come comes down, and also pain is also relieved. So that important message, as Sister Sreedevi said, you have to tell to the caregivers and as well as the patient. Otherwise, they will be panic. If there is any swelling happen, they will come to you and said, "Oh, sister, is edema there? So you please remove the needle." So that should be avoided. They will be anxious on that. You have to tell them. So we are going to insert the needle into the subcutaneous space, so that the absorption is very slowly happen. That important message you have to tell them. Thank you. Any other questions?
Ma'am, our video about subcutaneous is ready.
Yes, yes, you can play.
Thermoclysis. Mr. Mahesh has advanced cancer of pancreas. Mrs. Lakshmi is his wife and
Thank you for watching this video. Anybody have any doubts still have? Please ask. No questions? I hope you had a wonderful session from Sister Sreedevi. You all understand very well about subcutaneous infusion. I think if you don't have any questions, I would like to highlight few points on subcutaneous infusion and then wind up the session. So today also we don't have a patient story for discussion. So next session onwards, please bring a patient story. So because we need a patient for discussing such a relevant patient for discussing along with the theoretical part. So that's why we requesting you to bring a patient story for the session. So hypodermoclysis, subcutaneous infusion, we understand. What question? I don't understand.
I
Hardeep
think,
or,
I think why are we giving subcutaneous infusion?
yeah. So, Dr. Sreedevi, do you want to answer that question?
Actually, we already discussed that to prevention of dehydration and rehydrating the patient. For the purpose of this, we mainly given this patient. Actually, there is a doubt because of why don't we have IV infusion. So some in our setting, in palliative care setting and all, very difficulty to put the IV cannulation after chemotherapy and radiation. Very difficulty to put the IV cannulation. Otherwise, if we get IV cannula and IV site also in home care setting and all, we can manage with IV fluids and all. So that's condition for management of dehydration. We put the subcutaneous line and maintain that subcutaneous line for 5 to 6 days at that same site and given fluids through that area.
Okay, one important points I would like to highlight here is we have around 37 participants, I think. So after chemotherapy or radiotherapy, to be in frank, how many nurses will get IV line in one prick? So that we should understand, for avoiding multiple pricks, we need to give medication for symptom management. If there is a mild, moderate dehydration there, we need to give a intravenous infusion. But instead of that, you can think about that we can able to go through the subcutaneous. Shall we select that route? That important thing you should understand. Instead of IV, there is a choice. You can give fluid through subcutaneously. You can give such medication through subcutaneously. You can avoid multiple pricks. Then, which method you will choose? You will choose subcutaneous. Nobody wants to nobody is willing to get more pricks. Because of their helplessness, they will give their hand to us for giving putting intravenous cannula or subcutaneous or scalp vein set. So we are the person to give in the introducing inserting IV cannula. No, so we all know we have a skill, but at the same time, when they come to us, especially in palliative care, vein is not visible. Sometimes that is thrombogenic. That will not be if you can able to visible, then if you put a cannula, you will not get the IV route. So then you will get multiples. You will give prick to the multiple sites. So that is also we will inducing their pain. No. So you can choose subcutaneous infusion. That way we can able to give most of the medications for symptom management. So especially morphine, dexamethasone, Perinome, Buscopan, these all midazolam, these all medications which we are using in palliative care for symptom management. So that medications we can give subcutaneously. So better you can choose subcutaneous than intravenous route in palliative care. I hope your question answered. Anyway, because today we have learned many things, especially hypodermoclysis subcutaneous infusion. This is one of the safest and effective method of giving medication center fluid in palliative care. You can train the patient caregivers, because if you put a subcutaneous cannula, then you can train the caregivers. They can able to remove the IV set from the cannula. They can able to connect, but you have to teach where they can able to touch. They have to give they have to maintain aseptic technique. So that we should tell them. And also you have to convince the patient and the relatives, and also you have to convince your colleagues about the importance of subcutaneous infusion. So as we discussed earlier, some side effects will be there, like leakage. Sometimes, very rarely, the signs and symptoms of inflammation is there. That is also very rarely. If you can do the proper regular assessment, that we can avoid. So I think this is one of the best method. You can teach your patients no hospitalization is not needed, you can send the patient to the home. And also there is no chance of that blockage. This is in the subcutaneous site. Anytime you can remove and connect. So that is also important. You can tell the caregivers and patient. This is one of the good method. So that is also you should keep it in mind. I think if they don't have any questions, we can wind up.
Okay, ma'am.
Any more questions? Subcutaneous is great support in chemo cancer patient. Yes, for sure. Definitely. Chemotherapy patients, and after chemotherapy also you can give subcutaneous for relieving dehydration and relieving symptoms. That is one of the good method. Okay, shall we wind up? Sreedevi, do you want to add anything?
Nothing.
Nothing. So thank you, Sister Sreedevi, for the wonderful session. I hope they all understand very well from you about subcutaneous infusion, and also they had clarified their doubts also. Thank you others for your contribution. Thank you all.
Thank you,
Thank
ma'am.
you, Sangeet.
Thank you, ma'am. Thank you, Sreedevi sister, for the wonderful session. Thank you, Shiva ma'am, for facilitating in such a short notice, even if you are out of station. Thank you everyone for
Thank you.
participating.
Thank you. Bye bye.
Jagruti is present.